So for those of you who don't know me, my name is Azim. I'm one of the co-founders of BiteMedicine. We started these webinars almost a year ago now, which is a crazy thought. We started them at the beginning of that first lockdown. And I mean, it's been an honor and a privilege to be teaching you guys for almost a year now, all of you. And, you know, this has been an incredibly difficult time for all of you during COVID, whether it's been revising for exams, getting into clinical placements, whatever it is. So it's a real testament to all of your hard work. So keep it up. You're doing fantastically. And as I said, we're so honored to still be teaching you almost a year later. So yeah, if you ever need any help, support, whatever it may be, do pop us an email at admin@bitemedicine.com and we'll see what we can do to help you, because we're a very small team, but we try and help as much as we possibly can. So without further ado, today's webinar is on ABG interpretation, as I'm sure you can all tell by this slide. This webinar is super important and high yield, and it's really going to take us from the basics of ABG interpretation all the way up to some more complex concepts. So let's dive in. Just a little bit of an overview of the teaching schedule for the rest of this month. Schwabe did a fantastic kind of rundown on ECGs a few days ago. Today is obviously ABG interpretation. We've got IV fluids coming up, acute coronary syndrome, and then we've got our big national medical competition in a couple of weeks as well. So keep an eye out for that. Lots of prizes to be won there. So make sure you do attend if you can on the 27th of February. As I said, today is obviously the ABG interpretation webinar aimed at med students in clinical years. We have people all around the world attending, so we are honored to have people, you know, from everywhere here today, and also aimed at physician associates as well. Probably, hopefully going to be around 60 minutes. This webinar is building on the previous webinar, so ABG interpretation part 1, which was all about the physiology and the theory of ABG. So I'm going to try and move away a little bit from that this time around and move more towards the practical side of ABG interpretation and the stepwise approach, because this is an area which people find really difficult. So we're here to demystify some of those misconceptions and some of those difficulties. So if you are new here, you may not know, but we use a quiz, a piece of software called Mentimeter, which I'll show you how to use as we go along, just to try and keep things a little bit interactive. And then today, obviously, we're going to touch on the very basic stuff again. What is an ABG? Then the bulk of this is going to be the stepwise approach to ABG interpretation, working through a single scenario. And then we'll do a brief quiz at the end with cases of varying difficulties as well. So if you miss anything, do not worry. All of this will be recorded, you know, barring any technical issues, and will be uploaded as soon as possible. For all previous recordings, obviously, just have a look at the webinars tab within the app. Fab, and obviously, if there are any technical issues, if you have any questions at any point, you can use the Q&A function, and I'll try and resolve them as quickly as I can. So before we dive in, just a quick reminder of the fact that we have our unique and novel multi-step SBA question bank across all the main specialties. This gets uploaded and updated every single month. If you haven't had a chance, do check that out within our website. We have our online textbook, you know, written and updated by specialists and based on the most recent guidelines, and also our webinars, of course, of which one of them is the one you are at today. Fantastic. And obviously we have lots of new initiatives and things coming out in the next few weeks as well. So do keep an eye out. Lovely. So let's make a start. So this was really kind of the first slides from one of the first slides from the previous ABG webinar. But, you know, just to make sure we're all on the same page, let's start off with what is an ABG? Well, as I'm sure, hopefully most of you know, it's just a sample of arterial blood. You use a needle, you use a syringe, and it's typically taken from the radial artery, which is around the wrist over here. So when you feel your pulse, that's roughly where a good point to try and get a of arterial blood is. But you can also take it from other places, such as your brachial artery or your femoral arteries, which is known as a fem stab. The main reason we use a radial artery is because it's easy to access, it's not particularly deep, and as I had, it's a good collateral circulation as well. Thankfully, ABGs have been, to a large degree, replaced by venous blood gases in the emergency setting, predominantly because there's good correlation between the two results, other than in certain areas such as PO2, and ABGs are really painful. There were studies done which showed that patients were actually not coming to hospital because they were scared of the pain that they've had with an ABG in the past. So we try to avoid ABGs as much as possible, but there are obviously times when ABGs are important as well. So what I want you to imagine for basically for the rest of this webinar is that you are either a junior doctor or physician associate placed in A&E, based in A&E, and you are assessing this chap, this one case which we're going to start off with, who is presented to the emergency department. And you're assessing this patient, and you're going to be doing an arterial blood gas on them, and your role is to basically know how to interpret that blood gas. And then we're going to work through a bunch of other cases as well, working from the absolute basics to really complex stuff. So bear with me if you think, this stuff is too basic, etc. But we have to all start somewhere. So let's start from the basics and work our way up. For those of you who don't know what an ABG machine looks like, you take your sample, usually from the wrist, you got it in your syringe, you can take it to a machine which looks like this, or which is called your blood gas analyzer, and you get your results in seconds. And that's why it's such a fantastic test that can be done. Really good for acutely unwell patients, at cardiac arrests, for patients who you suspect have respiratory failure. It's used in things like sleep studies as well. So loads of reasons why you would do an arterial blood gas. And the great thing is, as I said, is that the results come so quickly. So I've briefly alluded to this already as to why a blood gas is useful. The main reason is that it gives you that really quick and kind of gold standard marker of your parameters, such as your pH, your PO2, your PCO2, various electrolytes. And because the results come back so quickly, it makes it a fantastic test, particularly for the acutely unwell patient. A good point was raised in the chat. They do use local anesthetic. It's not typically done routinely, although guidelines do suggest that we should be using local anesthetic more regularly because of the pain. In reality, you rarely see it done regularly. Normally, it's just a quick test that you do. You try and get in and out without faffing about too much. But yes, ideally, do try and use local anesthetic. So now we know the basics of what an ABG is and when you're going to do an ABG. So for example, respiratory failure, acutely unwell patients, cardiac arrest, those kinds of situations. So now we need to know our key values that we're looking at when we interpret an ABG. So as I said, all of this is building on our previous webinar looking at theory, so I'm not going to go into too much detail on exactly what all these parameters are actually referring to, but here's a basic rundown. So we have pH, which hopefully we all know from our GCSE biology and chemistry. pH just refers to acidity or alkalinity of the blood. PaCO2 is essentially a surrogate term for your CO2 concentration within the blood. It's the partial pressure of carbon dioxide in the blood, and this component is regulated by the lungs. So we call this the respiratory component. Obviously, if you're hyperventilating and you're breathing really quickly, you're going to puff off loads of CO2, and your PaCO2 is therefore going to drop. And conversely, if your respiratory rate is reduced, then your PaCO2 is going to rise. Your PaO2 is your partial pressure of oxygen in the blood. HCO3- is bicarbonate. So bicarbonate is essentially the most important buffer of acids. Once again, if you remember from your basic chemistry, bicarbonate is a buffer, which means it's the opposite of an acid. And it helps essentially, the more bicarbonate you have, the more alkaline your blood is going to be. And this is regulated by the kidneys, and therefore we call this the metabolic component of your arterial blood gas. Hopefully you're all following so far. We then have this concept of base excess. This is something which people tend to struggle to understand or not quite get their head around. Don't worry, I'll go into more detail about what base excess is, but essentially it's another surrogate marker that represents your metabolic component. So you want to look at your bicarbonate alongside your base excess. And then you have other components, things like electrolytes, creatinine, lactate, etc. So we're not going to be focusing on those. We're going to be focusing on our key values, but do be aware that there are lots of other components available on your arterial blood gas as well, which is part of the reason why it's such a good test. Lovely. Let's move on. So the next question is, we know what an arterial blood gas is. We know what, okay, so is anyone else, people seem to be having issues with the audio. Is that, some people are, some people aren't. Okay, if it continues to be an issue, just let me know and I'll see what I can do. So good, so most of you are okay, so that's fantastic. So we know what an arterial blood gas is, we know the components of it, but now we need to know how we interpret all of those components. And that's why I would agree with this kind of stepwise approach, which as soon as you get more, well-versed in interpreting ABGs, you won't even necessarily need to think of these 8 steps. They will come naturally. But to start off with, it's good to have a basic approach in your mind. And this approach is actually directly adapted from your Resus Council UK guidelines. So it's pretty well validated approach. So let's work through this with our chap that I'm about to tell you about. So we have our case. So case-based discussion number 1. So as I said, remember, you're working in the A&E, you're working in the emergency department, and you have this guy who's rocked up. Here he is with his very funky and edgy moustache. 65-year-old guy who's presented to the emergency department with a 3-day history of worsening shortness of breath and non-productive cough. On examination, he looks pale. There is accessory muscle use. He's got crackles in the left lower zone of the chest and has reduced air entry. So just pop it in the chat what you guys think. What do you think of this chap's observations? What is abnormal, if anything, and just what are your thoughts on the observations? Yeah, so I'm seeing lots of good suggestions there. So yes, he's tachycardic, he's tachypnic, his respiratory rate is high, his oxygen saturations are low, like you're saying. He's hypoxemic, his oxygen saturations are low, and he's pyrexial, his temperature is 38.1. So it's not looking good for this chap, and we need to figure out what's going on. And because of this desaturation and the fact he's acutely unwell, you've decided to do an arterial blood gas, which is a very wise thing to do. And the first question you're asking yourself, really, even whilst you're doing the blood gas, is, how is the patient? I think we've all come to the conclusion that this chap is not well. There's some suggestions in the chat about respiratory failure, etc. Well, you can't diagnose someone with respiratory failure until you've done an arterial blood gas. So, that's a prime reason why we're doing one in the first place. We need to see how unwell this patient is, and that blood gas is going to give us a good impression of that. So we've thought about how the patient is. We've thought, there's obviously some kind of respiratory pathology here. It could be COVID, it could be a lower lobe pneumonia, it could be lots of various different things. But all we know is that this patient is unwell with some respiratory pathology, and we're worried. So we need to get a blood gas. So that's the basic first principle done and dusted. Now, the next thing we need to think about is oxygenation. And the main question we're asking is the patient hypoxemic, i.e. do they have low blood oxygen levels? Now, a few key concepts before we can answer that question. Well, the first thing is obviously knowing your normal range. So everywhere kind of has different normal ranges. Some say slightly lower, some say slightly higher. But this is a pretty established range that people talk about, 10.6 to 13.3 kilopascals. So before you can answer the question, is the patient hypoxemic, you need to ask yourself, is the patient, we have to firstly understand this concept of oxygen percentage and the concept of supplemental oxygen as well. So ask yourself, is the patient receiving supplemental oxygen? Now, supplemental oxygen, for example, whether it's a mask like this, whether it's nasal cannula, this is represented as a percentage. For example, 24%, 35%, etc. But you have to look at this in the context of room air, because room air is represented at 21%. So those are a few key concepts to remember. In addition, we need to remember that your partial pressure of oxygen within your arteries is always going to be lower than the amount of oxygen in your alveoli. And that's understandable, because obviously there's going to be a reduction in some of that pressure as your oxygen goes into your lungs and then into your bloodstream. So the PaO2 is always lower than your alveolar oxygen. So these are three key points to remember when answering this question. So as a result of this point here, PaO2 is always lower than alveolar oxygen. We have to have some rough estimate of the degree to how much lower that is. So the general consensus within the community is that your PaO2, i.e. your arterial oxygen, should be 10 less than your inspired oxygen, i.e. how much oxygen you're receiving. So for example, if you're receiving 24% supplemental oxygen, your partial pressure of oxygen within your blood or your arteries should be roughly 14 kilopascals. So that's just a little bit of context for you there. And if you haven't quite got your head around that, that's totally fine. That's what we're going to be looking at next. So obviously, just another brief point to mention is that ideally you want to do an arterial blood gas on room air, but that isn't always possible. If there's supplemental oxygen and it's safe to do so, try and take the patient off oxygen for half an hour before you do the blood gas. Obviously, that's not always possible, in which case, do it on supplemental oxygen, make a note on the form, and then assess whether they're hypoxemic, depending on how much oxygen they're receiving. So some cases, so we have this 45-year-old lady presented who's 6 days post-op following a radical hysterectomy. She's receiving 24% oxygen. Now, don't answer this question in the chat. I'm going to try and use our Mentimeter if we can. So have a look at there. You can see Mentimeter.com there. So you've got a 45, can everyone see Mentimeter? I hope so. Everyone see that? If you just head to Mentimeter.com and type in the code at the top there, 9021745. And just to make sure that you have all fully understood this concept, what should the PaO2 be? And if you're wondering about how oxygen liters and percentages work as well, don't worry, we'll touch on that in the next few slides. So if you head over to menti.com, I'll let a bunch of you answer this and then we'll see and just make sure that everyone's on the same page. So if you head to menti.com and type in the code at the top there, you'll be able to take part in the quiz. Lovely. So you're spot on. 14 kilopascals. So that's just that rule. You're expecting your arterial PaO2 to be 10 less than your alveolar oxygen. So that's the reason. I know that seems like simple maths, but it's a concept which a lot of people don't fully appreciate. So fantastic. That's the explanation there. What about this guy? 75-year-old male with known COPD, presents with shortness of breath. He's receiving 35% oxygen via a Venturi mask. Let's head back over to Menti and make sure that everyone's on the same page here. You can type in the code if you haven't been able to do that last question. And as I said, I know this seems simple, but it's just to really kind of drive this message home. Good. I'm happy, and hopefully you're happy as well. That's absolutely spot on. Wonderful. So in terms of oxygen and percentages and liters, etc. This is something people get confused about quite a lot. An easy concept to think about it is in the concept of this Venturi mask. So that's what this mask is here. A Venturi mask is a really useful type of oxygen delivery method, particularly for patients with COPD, because you can give a very specific amount of oxygen to these patients. And the reason why that's so important in COPD is because a lot of these patients, well, a proportion of these patients are going to be chronically hypercapnic, i.e. their PCO2 is going to be elevated, which means that they're going to be actually be relying on what we call their hypoxic drive, i.e. their hypoxia to drive their respiratory function. If you give patients with COPD a ton of oxygen and they have a background of hypercapnia, that's going to make the condition even worse, and that's going to actually deteriorate their respiratory function. So we need to give them very specific amounts of oxygen, and that's why we use something called the Venturi mask. Now, a Venturi mask, as I said, is shown here. This delivers somewhere between 24 to 60% oxygen. So this chap was receiving 35%. And the keen-eyed of you will have noticed that there are lots of these different colored bits here. These different colors essentially attach onto the Venturi device and determine your flow rate going through your Venturi mask. The flow rate varies by the color. So for example, blue here, blue represents around 2 to 4 liters of oxygen per minute. And that is equivalent to 24% oxygen. So that's just an equivalence that we've calculated here. And it actually says it on the actual bit there. And whereas yellow, we go higher, this represents 8 to 10 liters of oxygen, which is around 35% oxygen. So that's what this chap would be receiving. And then the highest is green over here, and that's 12 to 15 liters of oxygen, which is essentially the highest, so around 60%. You don't need to learn those percentages. The key points here is that obviously liters correlate with the percentage of oxygen you're receiving. Those are two parameters to be really, really aware of. And it's important not to over-oxygenate in certain conditions such as COPD. And that's why Venturi is so brilliant, because you can actually just look at the side of these colors here and you can see the percentage of oxygen you're delivering and how many liters of oxygen you can deliver through that device as well. So a bit of background and making sure that you've all understood this concept, which can be quite difficult to understand, but hopefully I've made things nice and simple for everyone. Okay, just in the comments now, does anyone know what this mask is? What do we call this mask that this lady's wearing? So this is a non-rebreather mask. Yes, non-rebreather mask, perfect. So that's what this is, non-rebreather mask. Does anyone know what oxygen percentage this delivers? It's a tough question. Good. So around, I mean, in reality, it's around 85 to 90%, i.e. high flow oxygen via a non-rebreather mask. The reason we call this a non-rebreather mask is because this mask essentially stops the patient rebreathing almost any of their expired air, which is why the oxygen delivery is also so high, because you're not breathing in any air that you've already expired. That's why it's a non-rebreather mask. Who is it used for? Well, used for acutely unwell patients. Really, anyone who comes into resus will be put straight on high flow oxygen unless they definitely don't need it. So, you know, that's a really important thing to be aware of. And what is the flow rate? Well, around 15 liters. Well, it is 15 liters. 15 liters of oxygen via a non-rebreathe mask and that correlates kind of with around 85 to 90% oxygen percentage delivery. So I wanted to give you some background on hypoxemia, because it's not as straightforward as people often say. Like, you can't just look at the gas and say it's, you know, it's outside of the normal range. You have to look at supplemental oxygen. You have to look at, you know, various parameters before you can actually come to that conclusion. So as we said, what is even hypoxemia? Well, if we just look at it compared to the normal range, well, it is going to be a PaO2 of less than 10.6. but it can also be a difference between your inspired oxygen and PaO2 of more than 10, which is what I've clarified on the last few slides. If more than 10, then that can also be hypoxemia. So if a patient has been on a non-rebreathe mask for a while, and you do a PaO and you do an arterial blood gas and their PaO2 is 10.6, well, that's worrying because that's a lot more than 10. If their percentage delivery is 85 to 90%, a PaO2 of 10.6 is horrific. So although you might be normal in some circumstances on room air, it's not necessarily normal with supplemental oxygen. Other key points is how we define respiratory failure. Well, type 1 respiratory failure is a PaO2 of less than 8 kilopascals with a normal or decreased PaCO2, whereas type 2 respiratory failure is the same PaO2 of less than 8 kilopascal with a raised PaCO2. Unfortunately, I don't have time to go into all the differentials of type 1 and type 2 respiratory failure, but be aware of those differentiating features between the two, and also the fact that there are conditions which cause type 1 and different conditions that cause type 2. Okay, back to our chap. Remember, he's come in with some chest problems. We're not sure what's going on. It could be COVID, it could be pneumonia, but we have a patient, he's hypoxemic, and well, we think he might be hypoxemic, and this is his arterial blood gas. You don't need to memorize that right now. Hopefully on Menti, it should come up again. Let's have a look. So starting off nice and basic, so I can show the image to everyone, and you should be able to answer the question at the same time. So on your phone or iPad or extra tab, you'll be able to answer the question, and these are the values that you're looking at. Is the patient hypoxemic? Good. So hopefully you've all had a chance to look at that. Indeed, he is hypoxemic. His PaO2 is 9 on room air, which, by definition is less than 10.6. So he is hypoxemic, I would agree. And we certainly do have enough information because we've got the PaO2. Good. So that is PaO2 we've talked about, and hopefully that is something that that you've all understood. So moving on from oxygenation, we now need to consider what the patient's pH is and whether they're acidemic or alkalemic. So a little bit of background of regarding pH. Well, and this concept of hydrogen ions, etc. Well, the first thing we need to consider is the fact that the human body obviously undergoes lots of different reactions. H+ ions, hydrogen ions are produced, and we need a system in order to tightly control our pH within our physiological range. There are intracellular and extracellular buffers. I talked about this in the previous webinar, so I'm not going to go into too much detail here, but essentially we need a system to eliminate acids and thereby regenerate our buffers. And that's why we have the lungs, and that is why we have the kidneys. So the lungs regulate your CO2 and the kidneys regulate your bicarbonate. And as we said, the PaCO2 is going to be representing your respiratory component, and your bicarbonate and your base excess represents your metabolic component. So as your hydrogen ion, your blood becomes more acidic and your pH drops. This is acidemia. As your hydrogen ions drop, your blood becomes less acidic and your pH rises. This is alkalemia. Nice and straightforward, and your normal range is 7.35 to 7.45. And hopefully that's nice and straightforward and just something that you probably knew already. So we've got this guy, a reminder of what he's come in with, and we've got his arterial blood gas here. So the question is, what does the pH show? Hopefully you can all see this. What does the pH show? Have a look at that. So if you could answer in on Mentimeter, that would be brilliant, just so we don't give away the answers on the comment section. Dana in the comments made a good point. Yes, because some places use kilopascals, some places use millimeters of mercury when talking about PaO2, PaCO2. They're both just different units. In the UK, we often use kilopascals, but we can use both. I've just chosen kilopascals here because it's what I'm used to and what we use generally. So let's see what you all think. So I thought there'd be a bit of a split between those two. The reason why it's acidemia is what I will explain now. There is a difference between acidemia and acidosis, and similarly, there is a difference between alkalemia and alkalosis. So if we're getting really pernickety here, so acidemia refers to the low pH, below 7.35, whereas acidosis actually refers to the process leading to acidemia. So for example, respiratory acidosis would suggest there's a problem with the respiratory system resulting in acidosis. Technically, that's why this is acidemia rather than acidosis. So that's a very technical point, but something which consultants seem to, get very riled up about. So that's why this is acidemia, because the pH is less than 7.35. Okay, moving swiftly onward. So we know about oxygenation. Let's have a think about the respiratory component. This is directly from the previous webinar, so I'm not once again going to dwell too much on this. But the main point here is that when your ventilation is reduced, i.e. reduced respiratory rate, this is going to reduce your excretion of carbon dioxide, cause an increase in your PaCO2, and therefore this basically causes an increased acid load, and this is respiratory acidosis. Here are a few causes. This is not an exhaustive list, and there are conditions which can cause both, but this is how respiratory acidosis occurs. So raised PCO2, respiratory acidosis, reduced PCO2 results in respiratory alkalosis. So if your respiratory rate is really high, you're puffing off loads and loads of carbon dioxide, this is going to reduce the concentration of hydrogen ions in your blood, and this is known as respiratory alkalosis. Lots of different causes here as well. And anything which really is going to cause you to hyperventilate can contribute and cause respiratory alkalosis. So hopefully that's nice and straightforward. But just a reminder that, of course, there is a relationship and an interplay between your respiratory systems and your metabolic systems, which we're going to get onto very shortly. So let's assess the respiratory component of this chap now. So remember, we're going to be looking at the pH, and we're going to be looking at that PaCO2. So ignore the metabolic component. I know if you're jumping ahead and thinking about looking at bicarb, etc., don't worry about that. Just look at the pH and the PaO2 and the PaCO2 for the moment. As I said, we work from the basics and we'll work our way up to the top. Fantastic. Either you all knew this already or I'm actually teaching you something. Either way, I'm very, very happy. Almost 100% of you said respiratory acidosis. Perfect. That low pH combined with that raised PaCO2 such points towards respiratory acidosis. Lovely. So just a brief summary of what we just talked about. Well, acidemia, raised PaCO2, respiratory acidosis, alkalemia and low PaCO2, respiratory alkalosis. But where does this metabolic component come in? What do we mean when we talk about compensation? We have to bring it all together now. So let's move on to our metabolic component. We're going to be looking at bicarbonate. We're going to be looking at base excess. This is where things can get a little bit more tricky, but do not worry. We will try and make things simple. So as I mentioned earlier, the bicarbonate is a reflection of your renal or metabolic component or contribution to the control of your pH. always look at it in the context of your pH and your PaCO2 as well. As I also said, the bicarbonate is your most important buffer. It is a base, which means it's the opposite of an acid. So the more bicarbonate you have, the more alkalotic your blood will be. The less bicarbonate you have, the more acidotic your blood is going to be. Don't worry too much about these equations. I discussed this in the previous webinar, but be aware of the normal range and be aware of how bicarbonate contributes to alkalosis and acidosis. So if the kidneys fail to produce enough bicarbonate, obviously you're going to have an acidosis because you don't have enough of this base. And there are various causes listed over there. Occasionally, less commonly, you can have an excess of bicarbonate, and this can cause metabolic alkalosis because you have too much of this base present. So as I said, lots of different causes. You know, metabolic acidosis is more common on the whole than a metabolic alkalosis, and has lots of causes. You know, GI losses, renal losses, you know, lactic acidosis, diabetic ketoacidosis. All of these come under that umbrella of metabolic acidosis. Now, you're probably wondering, why is there a snail on those kidneys? I don't remember learning about the snail on snails in the anatomy of the kidneys. Well, the snail basically represents the fact that changes to your metabolic component are slow. These take a while. Your metabolic system takes a while to adapt to changes in your respiratory system. So often if you have a patient with COPD and maybe chronic hypercapnia, their kidneys are going to start retaining more bicarbonate, but that is a slow process because it's trying to slowly bring that pH back into the normal range. So it's not like the kidneys can suddenly switch on and start retaining more bicarbonate or excreting more bicarbonate. It is a slow process. Okay, so remember the key question in step 5 when we're assessing the metabolic component is, you know, what's happening to the bicarbonate and your base excess? Well, we've talked about bicarbonate. Let's touch on base excess now. This is a concept which people can find tricky. And to be honest, if you learn definitions like this, you're probably going to confuse yourself more than anything else. So the technical definition is that a base excess basically is a measure of the amount of excess acid or base in the blood as a result of a metabolic derangement. You know, these definitions are useful to an extent, but I find them more easy to understand if we break it down a little bit more. Really, because this is essentially a representation of your bicarbonate. So in other words, a base deficit, i.e. a base deficit of less than -2, is basically a marker of low bicarbonate. A base excess of more than +2 represent excess bicarbonate. So that's really all it is. I wouldn't get too bogged down in the exact definitions, but you know, it's essentially to back up your suspicion of a metabolic alkalosis or acidosis. So if you've got a metabolic acidosis, you would expect your base excess to be negative. If you've got a metabolic alkalosis, you would expect your base excess to be high because it reflects how much bicarbonate is actually in your system as well. And that's all base excess is. And this is just a basic summary of it. So base excess less than -2, we're thinking low bicarbonate and therefore metabolic acidosis. Base excess of more than 2, we're thinking high bicarbonate and therefore metabolic alkalosis. Really, that's really as simple as it can be. Good. So really, you know, we've talked a little bit more about how to assess bicarbonate base excess in the context of pH, PaCO2. Remember to always assess them alongside one another. I'm not going to repeat all of this already. I think I've said all of that numerous times now, but just remember to look at the pH and the bicarbonate together, and then, you know, the base excess alongside that is a useful indicator of the degree of metabolic acidosis or alkalosis. And as we've said here, it's you know, it's not quite as simple as this, but you know, you could essentially consider your base deficits and excess as, you know, almost surrogates for your bicarbonate. As I said, technically it's not exactly that, but in clinical practice, this is how you would generally consider it. Okay, So, but what about compensation between these components? Kind of what I touched on before is that, you know, these systems are not totally distinct, they're not totally separate. There has to be an interplay between the two, because if there isn't, then your pH will be outside of that normal range in patients with various comorbidities. So we need to try and keep that pH tightly controlled so that our cells can do all the reactions they need to do to survive. But how does that compensation work? So let's think about that. The compensation, the definition, really all it is that it's an appropriate attempt of the respiratory or renal system to restore your pH back to normal. And that's that interplay I'm talking about. So we need to have a look. So both, as I've touched on numerous times, you know, both your kidneys and your lungs can react to changes in each other. And the overall aim is to minimize any long-term changes in your pH. So before I get into the nitty-gritty of definitions and things, I think it's probably easiest to think about a couple of cases here. So we have to firstly think, what is the primary problem in the patient? And then we can consider if there's compensation. So we've got this chap here. This is a random guy. You know, he's come in. He's got some problem with his chest. He's acidemic. His PaCO2 is raised. So we're thinking respiratory acidosis. So that's your primary problem. And then you also look at the bicarbonate and you notice that the bicarbonate is elevated. And obviously this is the kidneys trying to respond to that acidosis by retaining more bicarbonate to try and essentially resolve that acidemia. So can you see that? So can anyone say in the chat what this would be called? What would you define this whole system as here? So as in, what's the definition of this this compensation? So we've got metabolic compensation, but what's the primary problem? Good, Pooja, perfect. Respiratory acidosis with compensatory metabolic alkalosis. So we can see here, respiratory acidosis. This has then caused the kidneys to respond by retaining more bicarbonate, and you're conserving bicarbonate, and this is a compensatory metabolic alkalosis. Let's look at another example. Look at this chap who's come in with abdominal pain. His pH is low and his bicarbonate is low. So what does that suggest? What does low pH and low bicarbonate suggest? Metabolic acidosis, exactly. As a result, you see that the lungs are puffing away. They're trying to get rid of all of their PCO, they're all their carbon dioxide. And as a result, your PaCO2 is reduced. So what do we call this setup? Brilliant. Metabolic acidosis with respiratory compensation. Everyone's got it. Spot on. Perfect. The primary problem is this. We can tell that this is the primary problem because if we were thinking, you know, could this be respiratory acidosis? Well, it can't be because the PaCO2 is low, not high. So that's why it has to be a metabolic acidosis, and that's why that's the primary problem. So you've all said it spot on, metabolic acidosis with compensatory respiratory alkalosis. The final thing we need to remember and think about is the degree of compensation, and this is really straightforward. If you have compensation and the pH is now within normal range, this is complete compensation. If the pH is still abnormal despite the attempted compensation, this is known as partial compensation. And you'll be able to grasp this idea much more with a few questions. So I don't like learning blocks of text like this because there is no understanding involved in learning blocks of text like this. My key was to make sure that you understood this whole process of compensation. But if you're someone who likes to have text, feel free to download the slides and have a read of this. This is just a wordy explanation of everything we've just talked about in terms of compensation. Okie dokie. And moving on to our overall impression. So our overall impression, really, we have a few options available. Well, it can really be any of these four, or it can be mixed. So I see Georgia saying, can you explain how to establish which is the primary component? The first thing, like we've discussed through this whole process, is the first thing you're going, one of the first, well, after hypoxemia, you're going to be looking at the pH. If the pH is low and the PaCO2 is high, you know that's a respiratory acidosis, and that's your primary problem. If you're thinking, could metabolic be my primary problem in this patient who's acidotic? Well, if their bicarbonate is low and their pH is low, then certainly that could be the primary problem. But if their pH is low and their bicarbonate is high and the PaCO2 is high, then that's going to be a compensatory reaction. It's all about making sure you follow those steps, and you'll figure it out the more you practice questions. And then also we need to think about compensation, but really this table helps to really kind of get these ideas sorted in your head. But really it's just about having an understanding of the values and practicing with some arterial blood gases, and that's what we're going to be doing next. So finally, with this chap, what is our overall impression of this guy's arterial blood gas? So what do we think is going on with this chap? Back to Menti, have a think. I'll just let a few more of you to respond. So hopefully you've had enough time to look at that. Let's see what you all think. Spot on. 92% of you have got it absolutely right. Well done. Respiratory acidosis with partial metabolic compensation. Now, the next most common answer was respiratory acidosis with complete metabolic compensation. Well, the way that we know it's not complete is the fact that the pH is still acidotic. This would be complete compensation if the pH was now within the normal range, but it isn't, and therefore that is why it is partial metabolic compensation. So well done, everyone. Almost 95% of you got that correct. So that's good to see. There we go. Respiratory acidosis with partial metabolic compensation. Brilliant. So I'm going to have to just have a brief touch on our other components. We've already really talked about this. We're not going to go into more detail regarding these, but just make sure that you're aware there actually a lot more valuable information on an ABG in addition to everything we've already discussed. You can get a quick look at someone's sodium, potassium, chloride, calcium, lactate, hemoglobin, various bits and pieces. It's really, really useful, a really, really useful test to do. Okay. So let's have a look at our quiz. So the quiz is basically just going to be working through a few cases of various levels of difficulty with arterial blood gases. I'll give you a brief explanation after each question, and there'll be a leaderboard at the end to basically tie it all up. There, it's just a bit of fun. There's no need, there's no competition, there's no prizes. But obviously there will be prizes at the future competition. Okay, so let's start off with question 1. Hopefully you can all see that. Question 1 of 5, everyone can join in. Okay, so let's start the countdown. All correct answers give you maximum points. There's the history, there's the blood gas result. What does the blood gas show? You have 1 minute. 20, 25 seconds left. A few of you still thinking. Three, two, one. There you go. Brilliant. Well done, everyone who put that answer. Let me quickly explain that to everyone. So we've got this 70-year-old chap. We think this is metabolic acidosis with partial respiratory compensation. As you can see, the pH is low, and it's persistently low despite compensation. So he's got, and the bicarbonate is low and the base excess is reduced. This is a metabolic acidosis. So that's your primary problem. You're puffing away you're puffing away carbon dioxide. So that's your respiratory compensation, but the pH is still abnormal, and that is why it is partial. So well done to everyone. The majority of you got that right, so that's really good to see. Next question. Okay, got a minute for this one as well. We could just, if you could answer on Mentimeter, it's probably better just to make sure we don't give away any answers. So you can head over to menti.com and type that code in at the top. Brilliant. Let's see what you've put. Good. Okay, so slightly fewer got that quite correct. So remember our definition of type 1 respiratory failure as well. So we've got this 58-year-old with likely COVID by the sounds of this. They have a respiratory alkalosis. So as you can see, pH is raised, so that's alkalemia. PaCO2 is reduced, so it's respiratory alkalosis. You can see the kidneys haven't really responded because your base excess is normal and your bicarbonate is normal, so there's no compensation. Remember, for respiratory failure, your PaO2 is less than 8 kilopascals, and the PaO2 here is 8.2, and that's why it's not respiratory failure. So well done to everyone who got that right. Let's move on to question 3. There's 5 questions in total, just in case you're wondering. Okay, let's go. All correct answers give maximum points. Ten seconds left. So Polly, if you could just make sure that you please answer on Mentimeter, not on the chat, because that means other people will see your answers. Thank you. Brilliant. Anxiety disorder. So those of you who'd like an explanation, here's a quick explanation. Well, what have we got here? Well, we've got, and you know, this is actually the next degree of questioning, because what you've done is you've figured out what the blood gas shows, and then you figured out what the cause of that blood gas is. So you've got a respiratory alkalosis here. Your pH is raised, so it's alkalemia. PaCO2 is low, so it's respiratory alkalosis. And there is no compensation. So that's the blood gas, and the most likely cause here is an anxiety disorder. So you're puffing off, you're potentially having a panic attack, you're puffing off loads of CO2, and you get a respiratory alkalosis. You know, pulmonary edema can cause respiratory alkalosis, but given the demographic and the history, is much less likely. Question 4. Oopsie daisy. Let me share that. There you go. Question 4 of 5. So this is now speed as well. Answer fast to get more points, just for a bit of fun. We don't encourage anyone to rush looking at their ABGs, but it's all about accuracy and speed in this case as well. Ten seconds remaining. There we go. So we didn't even talk about mixed respiratory acidosis and metabolic acidosis, or kind of mixed picture generally. But you're spot on. That is a mixed blood gas. And let me explain. So this patient has had a cardiac arrest on the cardiology ward. Patients who have had cardiac arrest will often have a mixed picture. So you can see here, you've got, and the reason that occurs is obviously if you're not respiring, you're going to get a respiratory acidosis because your CO2 is going to build up. And then you've got anaerobic respiration happening throughout the tissues of the body. So you can have a metabolic acidosis as well. And that's why that occurs. So you've got metabolic acidosis. So you can see your bicarbonate is low and your pH is low, and also your CO2 is high and your pH is low. So you've got a mixed acidosis within your respiratory and metabolic systems. So well done. The majority of you got that as well. Final question of our competition or quiz, and final question of the day. Let's go. Okay, 15 seconds left. Okay. Good, good. 81, almost, vast majority of you got diabetic ketoacidosis, so well done. So we've got this gas here, the last question, as I said. We've got this 19-year-old female, drowsy. To be honest, you probably could have got the diagnosis almost essentially from the history, to be perfectly frank. You've got acidosis, so the pH is low, acidemic. You've got PaO2, which is normal, a PaCO2, which is normal, but that bicarbonate and base excess are both low. So you've got a metabolic acidosis. You've also done a capillary ketone test, which is raised, very, very suggestive in combination with the history of a diabetic ketoacidosis. And the other ones are incorrect for the reasons described here. Okie dokie, well done. Let's quickly head over to the leaderboard. The main thing we didn't have time to discuss today is going to be anion gap. It's a useful thing to know about, well done to MRA. Take about 4,813 points. Well done to everyone else here with all these wonderful names. I hope you enjoyed that quiz. I hope you learned a lot. And really, that is your bread and butter ABG interpretation, rundown, essentially. Thank you so much for sticking around till the end. I'll take a few questions that I've got in the Q&A as well. We've got a bunch of a few new things coming out on the website. This will be recorded and be released. Look at all these things you've achieved today. Please do fill out our feedback form because we want to try and get better. We want to improve our platform. We want to improve these webinars. So I'd be really, really grateful if you could do that. Shoaib has kindly popped the link in the chat. Thank you for all your kind words, and I hope you found this a useful experience and that you've learned more about ABG interpretation. So thank you once again for attending today, and I hope you learned a lot. I'll have a quick look at the Q&A. What is the difference between hypoxia and hypoxemia? Hypoxemia refers to low oxygen in your blood. Hypoxia refers to reduced oxygen supply to your tissues. How do we determine if it's respiratory or metabolic component if a patient comes with complete compensation? How do we determine if it's respiratory or metabolic? So you're saying if a patient has a primary problem but it's completely compensated, well, there's going to be of those parameters in order for that compensation to have occurred. So for example, if you have a respiratory acidosis and it's been completely compensated, your bicarbonate is going to be elevated. So you know that there is compensation occurring for something. So there's always going to be something abnormal if compensation is occurring. So it's not that everything is going to be normal. So you have to remember that as well. Thank you. I'm so glad people found that useful. Thank you, Brenda. Thank you, Aura. Very much for your kind words. Unfortunately, I don't have time to go through all the questions in the Q&A, but I hope that you enjoyed it, and I'm glad you found my accent easy to understand. Greetings from Germany, greetings from London. As I said, it's been great to have you all here today. Stay safe, look after yourselves, and well done. Oh, New Zealand, that's great. If you're from any wild and wonderful places, feel free to write it in the chat. From Georgia, I've never been to Georgia or New Zealand. Anyone else from anywhere cool? India, lovely place. Norway, Romania. Gosh, what amazing. Malawi, Hungary, oh, Bulgaria, Wirral, Pakistan, Liverpool, Malaysia. Wow, Saudi. Really international we are here. Let's go. So nice to see. Philippines. Yeah, amazing. It's just the fact I'm in my tiny little flat in central London and I'm talking to people from around the world, and I hope that this has been a useful experience. So we'll be back for more, and we hope to see you back for more. Please do tell your friends, tell your colleagues about us, and we can keep doing these. Belgium, France, Portugal. Bonnie Bonnie Banks of Loch Lomond. Beautiful. Thank you, Polly. Well, as I said, it's great to see so many of you here, and lovely that we're so international here at BiteMedicine. And please do take care of yourselves, everyone, and we'll see you in a few days for IV fluids, I hope. Take care and all the best. Goodbye.